Young Chen Memorial Lecture. It's up there. And, Young was a physician here who moved to Colorado in 1998 or 9 from Loma Linda. And he basically, I think, was one of the first in the country to have the concept of a section of interventional or therapeutic endoscopy, where we would have a team of nurses and techs that were dedicated specifically to therapeutic endoscopy, and physicians as well. And he insisted on everyone being dually trained, which at that time was ERCP and EUS. And now it's obviously so much more training involved with advanced fellowship. The Rocky Mountain course began almost 20 years ago, and we did skip a couple years. And we've had an associated fellows course related to it. But Young was instrumental in initiating the course, as well as, I think, training a lot of physicians who are now in academic medicine. So it was a real privilege to be able to work with him. He recruited me here in a little while ago, 20 years ago. It's been a long time. And so we are fortunate to have Dr. Todd Barron, who will be presenting the Young Chen Memorial Lecture. And he's got a difficult task in talking about the unmet biliary needs that we have currently in 2022. And Todd is a professor of medicine and director of advanced therapeutic endoscopy in the Division of Gastroenterology and Hepatology at the University of North Carolina. And it's a real honor to have you present to us today, Todd.
Thanks, Raj. It's really an incredible honor to be able to give this lecture. I knew Young, and he actually invited me here many, many years ago. So again, it's an honor to be able to present this lecture. It's also, as he mentioned, a difficult task, unmet biliary needs in 2022 and beyond. So I was kind of racking my brain as far as what I was going to say, but we'll see what we come up with. This is one of my favorite quotes, and I use this quite a bit. I have thought about this during my career. Is imagination is more important than knowledge, by Albert Einstein. And really, when we do these very advanced procedures, especially the ones that are outside the box, we're often using more imagination than we are knowledge. So with that in mind, what are our unmet biliary needs? So I think the number one unmet need is still biliary cannulation. And despite how it looked and was actually relatively easily cannulation today, we have to recognize there is no cannulation technique that's 100% successful with 0% risk of adverse events. And cannulation techniques, when you think about it, have not changed dramatically since the inception. Yes, we use more wire guided than we did when it started. We use less contrast when we started, but overall, our cannulation techniques have not really dramatically changed. And so the cannulation as we know it, if we're going to change and have this unmet need where we can't have 100% cannulation technique that's got no adverse or very, very, very minimized adverse events, will require a paradigm change. Now, with each one of these unmet needs, I'm going to actually throw out some proposals, some of which are completely preposterous, but I had no other thing to go on. So what would be our future? How could we get around where we are now? Well, one would be possibly microcatheters and micro guide wires that are mounted somehow within standard catheters, such that you have the pushability behind them, but you can almost sort of weave your way through the folds. What if we had, now we can put drone cameras on the size of a fly? Why can't we have a tiny, tiny camera that will allow us to really directly inspect on the tip of the catheter and literally drive the catheter in to the papilla? Is that something? Could we give medications that specifically relax the biliary sphincter, or maybe really just open up the biliary sphincter? The other would be, what if we could somehow figure out exactly where the intraduodenal segment of the bile duct runs in the duodenum, and that you could directly target that and make your way straight through the duodenal wall, and bypass basically the pancreas and the actual opening. That would be called something like image-guided fistulotomy. So things to think about. But I do think for all of us, experts are able to get in the bile duct most, but even not all the time. And I think whatever we can do to make biliary cannulation easier and reliable would increase the utilization and the success rate for all endoscopists. Unmet need number 2 would be creation of true biliary enteric anastomosis. So we can create temporary anastomosis with colodoco-duodenal via stenting. So of course, we go through the duodenal wall into the bile duct, but after stent removal, the tract closes. So it's really not a true anastomosis. So what can we do? Can we make an anastomosis that actually would be something that would bypass an obstruction without the need of a stent, that would remain patent? So one thought, and this particular concept of what's called rare earth magnets is not new. There were case reports outside the United States for a variety of uses of rare earth magnets to create anastomosis. Specifically, they've been mostly reported when you've had a complete biliary obstruction and you were able to place a magnet above and below and actually open that obstruction up. But what if we could actually take these rare earth magnets, which are high-powered magnets, and what they do is they cause a pressure necrosis between the two magnets, so that when that occurs and you pull the magnets out, you literally have a hole that tends to stay open. And is that something we could do EUS guided? So we could perhaps puncture the bile duct, place a magnet above somehow through that, and then lay another one on the other side of the duodenal wall, and eventually allow a complete fistula to the duodenum. So that's something that maybe we could do in the future. Unmet need number 3 is ablation of extensive intraductal ampullary adenoma. So currently we can take out the external portion of adenomata. By the way, that is a real word, adenomata. It's the plural of adenoma. It can be endoscopically resected, but intraductal extension can be ablated with RFA, though invariably, because of the thermal effect, leads to stricture formation, which can be a problem in and of itself. So what could potentially be the future of intraductal ablation? Well, there is something that I learned recently about. It's called irreversible electroporation, IRE, and it's actually been used in fields outside of GI. It's a non-thermal ablation modality that induces cell apoptosis through the application of high voltage current. And it is actually FDA approved in fields outside of gastroenterology, not only for tumor ablation, but actually also cardiologists have been using it for ablation of pathways that create arrhythmias. So there's a review article from a few years ago in the Journal of Medical Ultrasound about irreversible electroporation for tumor ablation, and it's good general review. But basically, you have degrees. On the left side, you have your electric field, and you have your pulse length, and then you can see the degree of electroporation. So irreversible in the blue area creates cell death, and you can see if you go high enough on the electrical field and pulses, you can get thermal injury. But aside from that, you can get non-thermal ablation, which may actually allow us to do ablative therapies, not only for what I mentioned, but maybe other areas as well, without inducing stricture formation. Unmet need number 4 would be expandable stents with indefinite patency. So currently all biliary stents, including expandable stents, have limited patencies, and we know metal is better than plastic in terms of patency, but all stents that we place do eventually occlude. Repeated procedures are needed for management, depending on life expectancy, how many of these repeat procedures. We know that uncovered stents occlude due to tissue hyperplasia and or tumor in tissue ingrowth. And we know covered expandable stents occlude due to sludge formation. So possibly the future of biliary stent patency, and this is a very global statement, is maybe we need to develop novel materials that we don't currently have or not currently use that would somehow incorporate into the biliary tree above and below a stricture that not only prevent biofilm formation, which is what leads to the sludge formation, but also in some ways covering to prevent tumor ingrowth and tissue hyperplasia. Unmet need number 5, practical 3D imaging during biliary ERC. So there are some softwares out there, 3D imaging software is available on some very expensive fluoroscopy units, and they're not that easy to use. You have to do a fair amount of rotation and almost do like a tomogram of the patient. And where this would be useful is in the endoscopic management of complex hilar biliary obstruction, because deciding exactly 3-dimensionally where these segments are that we need to drain can be extremely difficult. And so there was a case report in 2020 of a new technology of 3D biliary CT for ERCP related procedures. It was a case report. But as you can see, they were able to actually have this 3D reconstruction and also use it during the endoscopic procedure with various overlays to try to figure out exactly where the catheters. In this particular case, there were plastic biliary stents that you can see in blue on the reconstruction and the segments they were in. The red is the tumor. But again, we're working in a 2-dimensional world, doing these complex procedures that really would be best served with 3-dimensional anatomy. And I'm going to end with unmet need number 6 is reliable diagnosis of cholangiocarcinoma, which came up today. Our patient may or may not have cholangiocarcinoma, but we discussed that intraductal biopsies and cytology are often non-diagnostic due to the serious nature of the disease. And of course, tissue diagnosis is essential for management in these patients. So what would be potentially the future of tissue diagnosis of cholangiocarcinoma? Perhaps we can have intraductal catheters that somehow allow us to get transmural core biopsies of tumors. How we would direct that is unclear. More than several years ago, there was something called a Howell needle, which was an FNA needle inside a catheter that you would put under fluoroscopy into the bile duct and get aspirates of intraductal tumors, but the material was relatively scant. What we would need is some sort of aggressive catheter. In the past, believe it or not, atherectomy catheters have been proposed, and there have been small series on using very aggressive atherectomy catheters in the bile duct, although that really never took off. But perhaps we can somehow pair this, or again, have some sort of transmural biopsy needle that would go from the bile duct into these tumors. So in conclusion, there are a finite number of unmet biliary needs. I probably could have thought of more, but for the most part, we are obviously successful in what we do. We can always do better. I think addressing these unmet needs requires imaginative solutions. And perhaps the way we would move forward on looking at this is to have endoscopic think tanks, to really have experts come together and say, what do we agree on the true unmet needs within the biliary system, either with ERCP or EUS, and partnering with industry may allow these ideas to come into real world application. So with that, again, I appreciate the opportunity to give this lecture, and I'm happy to take any questions. Thank you.
Any questions from the audience for Dr. Barron?
We have one, I think. Just shout it out. Don't be shy. Right. Right. So you're saying DNA analysis, right? Right. So people have used obviously FISH, fluorescent in situ hybridization. There are false positive and false negatives with that. But you're right. If we could harvest DNA from the bile, assuming that there's enough sloughing of tumor, and there should be, into the biliary tree, and then have a something specific enough that would say this is 100% diagnostic for cancer. Certainly that might also be another way. So that's a great idea.
Todd, when you've looked at, I really appreciate your lecture, and when you look at the existing devices for tissue sampling and the limitations, I think we often are thinking about changing the devices, but is it so much that, or is it just what we're utilizing to make the diagnosis,
right,
such as
right.
this analysis? So is that a more futuristic idea than?
Yeah.
Because currently we just keep talking about different devices.
Yeah. Yeah. I mean, as you know, even with F&B, it's not only the device, but there's operator dependency. There's a lot of features that go into whether or not you end up getting a diagnostic biopsy. But certainly, the more tissue acquisition you can get, the better. Not sure that answers your question, whether that's going to require different devices than what we have or better iterations of what we already have, like completely different, or iteratively, do we do better in needle design for tissue acquisition, for example, in EUS?
Is there, if you were to think like 10 years from now, when you're still in your the middle of your career, 10 years from now, Todd, since you're 30, what do you think what do you think is going to happen 10 years from now that's going to make your job in the ERCP suite easier? You're still doing cases, but
yeah,
what do you think might be that thing, I don't know, 10 years from now?
Yeah, to make my job easier. I don't know. Easier also depends on the kind of cases you're taking on, right? So, I tend to take on more and more and more challenging cases, so it never totally gets completely easier because you're trying to raise the bar a little bit more and a little bit more. No, I haven't thought that far ahead.
Todd, I was struck by one of your first statements in terms of we need to have a technique or a procedure or a device that really eliminates the adverse event rate. so that we can get to like a 0% adverse event rate while
Yeah.
having a 100% cannulation success rate. And I'm always struck, like, we always have these cases where cannulation is so easy, but they still get post-ERCP pancreatitis.
Yeah.
We're so concerned about post-ERCP pancreatitis, and rightfully so. And we keep on focusing on ways to prevent post-ERCP pancreatitis with medications or prophylactic kidney stenting.
Yeah.
But what do you think is the future of that in terms of how can we really eliminate post-ERCP pancreatitis? Because that really is adverse.
Yeah. No, I agree. I mean, I think what you're going to see, and you're already seeing it, is that EUS guided drainage procedures are going to be to the point where it's going to be accepted as equally, an equal up. Right now, we're using EUS guided transmural drainage when the ERCP fails. And we know there are randomized trials that suggest it's as good. One option obviously is that we don't even cannulate anymore, right? But that's still not going to handle bile duct stones. That's good for malignant biliary obstruction, where you can do everything around the papilla, avoid the pancreas. Obviously, that has its own set of adverse events, but I think as we get better and better with the US, those will also come down. So obviously, one way is to completely avoid ERCP if you can do that. But to your point, how can we get to the point where we can get into the bile duct, do these things, and not cause pancreatitis? And some way, I think we have to get there. The question is, how can we get there? And I don't know, how we will get there.
Thank you so much, Todd.
Yeah, thank you.
We are going to break for lunch. We'll be back here at 1 p.m. And please do visit the exhibitors and get those passports filled out for that very exciting raffle. It's going to happen Saturday. You don't want to miss this. Again, 5 $100 Visa cards. I highly encourage you to fill those passports. Thank you. You wanna go?
Yeah, Natalie, you're
Back up and running.
Where do you want to have lunch? You want to have it here, or where do you guys want to have lunch? You want to have it here or over there? Maybe better here. I think so. This is gonna get cold. Wait, you guys want to head to that, and then I'll find you guys when I'm walking over. Can you do that?
shows where you. Oh, okay. So you're staying in.
I'm staying here.
Yeah.
Okay. Good.
Thanks, Sam. Thanks for being available.
Sure.
Thanks, Natalie.
Yeah, that was great.
Yeah.